Good evening, everyone, and welcome. My name is Anas Ndijani, and together with my colleague Dr. Ahmed Saidan and Dr. Faisal Zaghaibi, we'll be hosting for today's session. On behalf of the Saudi Prosthodontics Society, we would like to welcome you all in our webinars. We appreciate your attendance and interest for such online lectures. Before I hand over the mic to Dr. Ahmed and Dr. Dean, I'd like to make an announcement. The Saudi Prosthodontics Society would like to announce about the grant competition. Starting from the 9th of April till Sunday the 19th of April on our Twitter account @SaudiProstho, all of the participants who have answered correctly to the daily questions, whether or not they have won in the daily competition, will still have a chance in the grant competition. The chances of winning in the grant competition will increase simultaneously every time the participant answers a daily question correctly. For example, just to make things more clear, if the participant answered 4 daily questions correctly in the given duration, his or her name will be duplicated 4 times in the final draft. In addition, the Saudi Prosthodontics Society would like to announce that there will be three prizes by the end of Sunday, the 19th of April. First and second prizes will include tickets to attend the IDS Cologne conference in Germany in 2021, including traveling and accommodation. The third prize will be an intraoral camera that costs approximately 7,000 Saudi riyals. Further notice that these terms will be applied only by the SPS member. Also, as the number of attendees of the scientific webinar activity presented by the Saudi Prosthodontics Society has increased dramatically in the past days, it has been decided to add an additional daily prize for those who wins the daily competition. In addition to a free membership, the winner will receive a voucher of 1,500 Saudi riyals provided by Amasi Tamayus Company. The award will be provided until April the 19th of 2020. So if you're not yet a member, you can scan the QR code in front of you or visit our Twitter account to find the registration link. Now, without any further ado, Dr. Ahmed, the mic is yours.
Hello, everyone. My name is Ahmed Saidan. I am one of Dr. Morton's resident currently at Indiana University School of Dentistry. Dr. Morton has completed his dental training in the University of Sydney and his Master of Science in Postgraduate Certificate in Prosthodontics at University of Iowa. He is an endowed professor in the Department of Prosthodontics at Indiana University School of Dentistry. He also serves as the director of the Center for Implant, Aesthetic, and Innovative Dentistry, and he is the assistant dean for strategic partnership and innovation. Dr. Morton is a diplomate of the American Board of Prosthodontics, where he serves on the board of directors, and he is one of the few board examiners in the States. He serves on the board of directors for the International Team of Implantology, or the ITI, and he is also a fellow of numerous organizations, including the American College of Prosthodontists, the Academy of Prosthodontics, the International College of Dentists, and the ITI. He is a fellow dental surgeon at the Royal College of Surgeons in Edinburgh, and he has published more than 120 peer-reviewed articles and lectured widely on prosthodontics, implant dentistry, and aesthetics. And on a personal note, Dr. Morton is one of the few people that possesses a huge wealth of knowledge, and it's an honest pleasure today to be introducing him and to be able to learn from him and work with him on a daily basis. I hope everyone gets to learn from him today, because it was my pleasure doing so for the past 3 years. Thank you. And Dr. Morton, if you unmute yourself, you'll be able to share your screen and start your presentation.
Okay. Thank you very much for your kind introduction. I hope you all can now see my screen. If there's any problem, you can speak up and let me know. I want to thank the Saudi Prosthodontics Society for this kind invitation to spend some time with you talking about leveraging workflow options, finding success, and avoiding complications. It's an interesting topic for me because it blends together not only workflow options that are contemporary, digital if you like, but it also allows us to review in some ways protocols that have stood the test of time, that we understand, and that have a body of evidence to support them. I would like to start by seeing if I can get things
Dr.
moving.
Dean, can you just press on this slide?
Yeah, there we go.
Yes.
Okay.
there we go.
I would like to initially acknowledge the people I work with. Across the bottom, on the left-hand side, dressed up as dominoes, are the wonderful staff we get to work with every day. Our implant center and our residency program rely heavily on the staff that work with us. And I think very often staff are not acknowledged appropriately, but they make our job much easier. On the right-hand side, I feel very privileged to be close to all of our residents. We have more than 18 residents. Each year we have ITI scholars, as you will see in a second. We have fellows that spend time with us. They really drive our program to be contemporary and to be innovative. And I think it's very important to acknowledge that their desire to learn makes us as faculty better at providing them with that opportunity. On the left-hand side of the faculty that you see in order, Dr. Lin, Dr. Polito, Dr. Yang, and Dr. Dutra. These are the 4 faculty members that I spend most of my time with each day. They are here at Indiana University. Dr. Lin is the interim chair of our department. He is also the program director for our residency program. He and I have been strong collaborators for more than a decade, and we get along very well as teaching. Dr. Polito has been a friend of mine for a long time through the ITI. We think similarly about how to manage patients with dental implants. He's a maxillofacial surgeon and the interim chair of the Department of Oral and Maxillofacial Surgery here at IU. Dr. Yang is next. He's one of our younger faculty members, but he's board certified and he's very involved in the teaching of dental implants and the teaching of basic prosthodontic principles to both our dental students and our residents. And Veneered Dutra on the right-hand side is an oral maxillofacial radiologist. As we embrace more contemporary workflow alternatives, the importance of radiology cannot be understated. The next 2 guys that I would like to introduce on the left, Dr. Will Martin has been a collaborator and quite possibly my best friend in terms of just life as well as a dentistry for more than 20 years. He was my partner at the University of Florida along with a surgeon, Jim Ruskin, and we have worked together closely for a long time, even if we are not at the same facility. On the right-hand side, a young guy, Alejandro Lanes from Chile. He's a gifted clinician and a wonderful educator, and he has provided for me some patient care, as you will see as we go through, but we'd like to consider him one of our partners as well. From my time at Louisville, on the left-hand side, you will see Brian Harris. His name comes up regularly in the presentation, as does that of Amir Zandinejad. Brian is at Louisville still in private practice, but his association with me was through the university. And Amir is at Baylor, Texas A&M, College of Dentistry in Dallas. These are the guys that really have played a big influence on the patients that you see and on the way we think when we educate people. Very important for me is to recognize the ITI. The ITI is a non-profit global organization devoted to implant dentistry and related fields. These are all collaborators of mine that have been ITI scholars. You can see the diversity of the program is amazing, and really they bring to me as much as I ever give to them in terms of knowledge and desire. The ITI scholarship program has been just a benefit for me in every way. So I'd like to recognize all of them as well. I'd like to begin by quoting an article from the 50s. A prosthodontist named Devan a long time ago said to us that our goal as dental clinicians or as oral care providers should really be to obtain health before we intervene with treatment and provide treatment that maintains health after we have managed the care of the patient. This is a really strong philosophy to embrace even today. In the 50s, it was devoted predominantly to managing a patient in terms of dental caries, oral health disease, in terms of periodontics. Today, obtaining health involves beyond just caries and periodontal disease. It involves orthodontics and endodontics and patient management in terms of their psychological positioning for maintenance of care that we provide. But as a prosthodontist, it all comes down to, as you see on the left, establishing health, as you see in the middle, documenting where we are going to start the care and providing ourselves with an opportunity to go back to that point at all times. And on the right-hand side, a simple diagnostic wax-up that really provides us with an opportunity to see where we want to go. These principles are still in place. It doesn't matter if we are working in a traditional or a conventional workflow. It's just as relevant when we work in the digital realm. In the middle, you see diagnostic wax-up being performed using a computer and a mouse instead of an articulator and a diagnostic wax-up. But it does the same thing. It identifies for us where we want to go. The principle is the same. On the right-hand side is really a big key difference between conventional or traditional workflows and what we do as a routine today. It is really using or leveraging digital technology to enhance communication through the process of radiology, through the process of software that allows for the planning of a dental implant and the planning of the restoration that we are planning for the patient. The opportunity to visualize all of these things together on the one computer screen is an important advancement. And that's really where I want to spend some time discussing how we can use contemporary alternatives to enhance the quality of the care we provide for patients. And this is important because complications are not unusual. If you look across this screen over 20 or 30 years of practice, each one of the letters represents a complication that has occurred in our practice or has been referred to our practice. As you follow it across, some are associated with implants, some complications are associated with the restorations we provide on implants, some are associated with conventional or traditional workflow. Some are most definitely associated with a contemporary or a digital workflow. There's no magic cure for complications. They are going to be encountered if you see patients. We are unable to provide perfect care. We are professionals and we are considered to practice because perfection is not necessarily an expectation. What is an expectation is that we will try and get as close to perfect, if not perfect, each time we intervene with a patient, and that's an important philosophy to embrace. Complications can be associated with the assessment of the patient. We can make mistakes in terms of how we plan, and we can certainly make mistakes, as you can see, with execution. There's no magic bullet for completely or partially edentulous patients. Complications occur in a wide variety of manners, in a wide variety of patients that we see. But in order to manage complications, we should be doing our best to avoid them from the start. So assessment and treatment planning, these are still the cornerstones of a successful practice, whether the practice is about restoring implants, whether it is about placing implants, or whether your practice is about both placing and restoring. I can't overemphasize the importance of assessment and planning to have a protocol in place that maximizes the opportunity for an outcome that's satisfying to the patient and the clinician. And then we can execute and go through that pathway. If you like, you can go back to the literature. Complications and risks are nothing new. This is an article from 2004 that defines some of the factors that are associated with mechanical complications. The mechanical complications are associated with prefabricated components. Technical complications are associated with the parts and pieces that we, the dentist and the laboratory team, put together to provide the patient with. These kind of risks need to be understood, and they need to be identified before we begin, so that the clinician can come up with a treatment protocol that minimizes the likelihood of complication occurring. This is important not only for the prosthodontist, but it's also important for the clinician that places the implants, because very often biologic complications are not only associated with margins that don't fit or crowns that are poorly contoured. Sometimes a lack of marginal integrity and less than satisfying contour of the restoration is necessary because implants are placed. Very often, clinicians look for a straightforward answer, the difference between, for instance, cementing restorations, which many people say is something that we can't do with dental implants, that cementing restorations is a problem. I would like to put forward that it's not the cementation that's the problem, it's excess cement, part of attention to detail, that becomes a problem for the biologic tissues that the implant and the restoration are associated with. So here on the screen on the left, you see just pristine tissue associated with cemented restorations, but not associated with excess cement as part of that protocol, because the meticulous attention to detail of the clinician, in this case, Dr. Martin, allowed the tissue to respond in a biologically satisfying way. In the middle, we have screw-retained components that, with no cement and nothing other than the proximity of the implant and the contour of the prosthetic intervention, is causing all kinds of problems for the tissue. And as you see on the right, crowns cannot be contoured appropriately if implants are malpositioned. And a long time ago, Dr. Boozer, in partnership with Dr. Martin and Dr. Belser, they published an article about danger zones, where implants can be positioned so that we can anticipate a good biologic response, or if they can be positioned in a manner that presents threat. And these danger zones need to be avoided. So I'm going to assume that all of you listening to the lecture are aware of negative impact that the clinician can have on the outcome of the treatment, whether you place implants or whether you restore them. Complications cannot simply be assigned as a problem of the prosthodontist or a problem of surgeon. It's a problem that the team needs to manage. And I think really avoiding complications is the preference rather than managing them. And conventional methods and conventional knowledge cannot be overlooked. Simple things like how to fabricate a denture that's appropriate, how to position teeth that are appropriate in terms of phonetics, aesthetics, and the ability of the patient to chew or mastication. If you look across the screen, you can see patients are often presented with a prosthesis that does not satisfy these basic principles. And when they do receive the denture, very often the blame is assigned to the denture. And very often it's not the denture that's the problem. It's a bad denture that's been made by a clinician that's inadequately educated on the fabrication process. And I think this is one of the problems we have with education, taking dentures out of a curriculum because we don't see as many patients as we used to. We are beginning to understand that learning about a denture setup and tooth arrangement and the shape and contour of the denture base extension is more about basic principles of dentistry and not just complete denture prosthodontics. So you can see the existing prosthesis, second from the left, over-contoured lip, but in the third one you see that the patient needs support from the prosthesis, and I think in the fourth one you see that the prosthesis, it's the teeth really that need to support the lip rather than the denture base extension. This can only be managed, and avoiding the complication can only be undertaken if the clinician is clear and has a clear understanding of what they're looking at the planning and assessment phase of care. Because when you start a diagnostic wax-up for any intervention that we provide, whether it's edentulous arch or whether it's a partial edentulous arch, we need to think about restorative volume or space, not only for the teeth, but for, as you can see from the wax, the denture-based extension, or a part of, if this was a fixed restoration, the transition from tissue to tooth, whether it's made from ceramic material or whether it's made from an acrylic material. We still have to account for it in the assessment phase if we are going to avoid a complication associated with poor planning. We need to know about the occlusion, the occlusal scheme, the involvement of opposing teeth, presence of parafunction. Often these are overlooked by clinicians in the assessment phase when they manage a patient that's requiring implants. Again, whether it's edentulous or partially edentulous, these are basic principles that need to be thought of before a treatment protocol is come upon if you're going to avoid complications. Of course, we have aesthetic complications that occur more and more in a contemporary world. And because of the opportunity to utilize implants in a more broad sense for patients, the complexity of care that clinicians come up against is much more diverse than it used to be. Just managing an edentulous arch with a high water hybrid design, when you only have one opportunity, you can master that more in a more straightforward way. But choosing between a conventional hybrid, a hybrid that includes milled frameworks and cemented CAD/CAM teeth, and whether we go with a monolithic hybrid fabricated from zirconia, these procedures, even though they are digital and the assumption is the contemporary digital pathway might be better, sometimes the complexity of actually performing the procedure can make it more likely to be associated with a negative outcome for the patient. And then, of course, maintenance. We should be thinking about the patient's ability to maintain right from the start. Avoiding biologic, mechanical, and technical complications is most associated with appropriate treatment planning and appropriate intervention by the right clinician. And the ITI a long time ago published a book on SAC that defined patient care as being straightforward, advanced, or complex, and hopefully helps people identify if they are the right clinician to partner with the patient in providing care. And one of the things Professor Boozer says that I really like is that the number one risk factor for the patient is who they choose to provide the care. And the clinician is really the key. And we'll talk about that as we proceed a bit further. But we need to understand that the intervention by the clinician, if it includes implants or if it doesn't include implants, we are trying to find a way of restoring something that's compromised from a biologic point of view. And our planning should not focus only on the prosthesis or the prosthetic side, inclusive of placement of implants. But we need to understand how that will interact with the existing biologic conditions the patient brings. And here is an example. A fixed prosthesis with good bone gives us an opportunity to provide an emergent profile, fixed restoration for the patient. But if this patient comes in with a failing dentition, trauma, and loses teeth, they have not yet lost bone. And very often, inexperienced clinicians are prepared to place implants and are happy to do so in a patient like this that has good bone volume. But if the patient has an inability to tolerate a fixed prosthesis for whatever reason, whether it's functional, whether it's ability to maintain, whether they have underlying health conditions that prevent it, trying to provide a removable restoration here as a second choice with implants positioned with a fixed restoration in mind leads us to complications because we have too much bone. And one of the controversies that is associated as part of implant dentistry today is the preservation of bone. The preservation of bone is a principle we should all adhere to. But when the bone interferes with the provision of a prosthesis that's functionally, aesthetically, and phonetically satisfying to the patient and clinician, sometimes we do not have the benefit of resorption here, and we need to modify the environment into which the implants and the prosthesis will go. We often have an opportunity to perform an alveoloplasty to remove some bone to give us an opportunity to provide the prosthesis with the best opportunity to function. And very often, a reluctance to remove bone, the end result is a complication to the prosthesis because the prosthesis that we can provide is not supported by the biologic circumstances of the patient. So very often if a patient comes in on the left-hand side but needs a removable prosthesis, I like to think of my surgical partners here as accelerating biologic resorption that would have occurred had the teeth been removed for longer or had the patient responded in a different way. And very often dentures are considered to be the problem here when a good denture cannot be fabricated because the biologic conditions do not support it. So this brings us to really something that's very important, whether we talk about conventional or contemporary workflow alternatives, and it's space. prosthodontic volume and the importance of prosthodontic volume cannot be understated. Very often you'll see numbers in red here. These are often given to us as minimum numbers that the clinician can work with. Abutment height of 4 millimeters, a framework dimension of 2, and a veneering material of 1. If you put all of that information together, you get 7 millimeters, which I've often heard as being the minimum amount of space you need for fixed restorations that are supported by implants. But 7 millimeters is less than the natural tooth length of any tooth that we have. So you may be able to screw retain something into the patient's mouth, but it's hardly a restoration that duplicates what's missing. The teeth won't look right, they won't function right, and in the long term, they can't be as reliable if we push these numbers. So these numbers, even though they're a minimum usable amount of space, it's not a minimum amount of space that we should work with. On the right-hand side, those are the numbers that we should look for. Total of 12 millimeters. These are numbers that are much more achievable if we are going to provide the patient with the prosthesis that looks, functions, and performs the way we would like it to from a masticatory point of view, to the level of satisfaction the clinician and the patient are looking for. Conventional methods are often required to overcome what I would say are some digital complications. There's no question in my mind that the ability to use CBCT and the enhancements that have come about because of this technology have changed for the better the way we will practice in every way, shape, and form. But it's like a language that you can't speak. If the clinician is not able to gather the information that's given to them in the CBCT and utilize that as part of the assessment and the planning process, we often end up with a compromise. So here we have CBCT, some reconstructions that we can look at that clearly establish there's enough bone for dental implants. But what the clinician that placed the implants was not able to recognize from this is where the teeth should be for an ideal restoration. So the relationship between the bone and the planned restoration is not always something that we see in the CBCT alone. And many of our surgical partners, they often plan for the positioning of implants without necessarily achieving the right consultations from partners that are going to restore. And this leads us to an unhappy patient. Here you see the implants were placed in the available bone, but the available bone and the tissue did not work very well with the planned restoration. So we end up with the ridge lap complication. It's impossible for the patient to clean. There's inadequate space for the restorative aspects of the prosthesis to perform from a mechanical and a technical point of view. So we start to see fractured components, teeth breaking off, and we start to refine the occlusion, because in this case, opening the occlusion was not something that the patient was able to tolerate. So it becomes a very difficult problem then to overcome, and a very expensive one. So we go back when these problems result from embracing a contemporary pathway, but with inadequate knowledge. We have to go back then to conventional workflow pathways, articulate the existing restorations, articulate and transfer to the articulated the vertical dimension of occlusion, and then simply making a vacuform matrix and positioning this on the casts shows where the residual ridge and implants are in relation to the restoration that can be provided. And you can clearly see in both arches, the biologic part of what we do that the patient brings is clearly compromising how we can restore the patient. And in this case, the implants make it more challenging. And I would like to say to you, I would much prefer no implant to a bad implant. A bad implant makes the life of the restoring dentist extremely difficult. As difficult as a good implant may simplify things, a bad implant can really make a challenge for what we do. So as a clinician, I would go back and fabricate provisional restorations, always perform provisional restorations. One of the ways of avoiding complications with a definitive restoration is to do a provisional that duplicates your final restoration as accurately as possible, so that you can evaluate, modify, and interpret the information the patient will bring back after wearing your provisional restoration for a period of time. This is an important key. Avoiding complications, it includes provisional restorations to give us an understanding of how our planned restoration will perform. If you do that, we can go ahead and restore the patient, but in this case with very, very difficult care. These are high noble alloy occlusal surfaces. We have to coordinate that with ceramic surfaces that function in the long term. So the relationship between the framework design and the longevity of the veneering ceramic, basic principles of a conventional pathway, a match of coefficient of thermal expansion, the ability to obtain a passive fit. Each of these, what I would call straightforward protocols in a very complex patient, very difficult to achieve. So the standard here is to make sure that at every stage we do what we can, because every stage of care influences the ability for us to find an outcome that's satisfying at the next level. Every stage influences the success or the outcome of the stage following. And that's a very important thing that we need to embrace, because we do have an opportunity to use a contemporary workflow pathway to enhance what we do. You see on the left-hand side, on the articulator, we have a planned prosthesis, complete on complete dentures that we can take to the mouth. We can use a dual scan technique to transfer the information that we've developed on the articulator and superimpose this as part of the information we get from the CBCT. This is an important delineation for me, because the middle two we can also do utilizing a completely digital pathway. But then the clinician needs to understand that what they do on the computer is the same as what we would do on an articulator. Not everybody is as proficient at seeing on the articulator what they are going to interpret on the radiograph, and vice versa. Not everybody can see in the CBCT information in conjunction with the design protocol or a design software package that you see on the right. Not often can the clinician transfer as much information or as much understanding as they would using an articulator. So there is a distinction here. On the right-hand side, you want to be able to see and understand what we see in the conventional world if you are going to develop a treatment plan that works for the patient. We have to be able to understand that this gives us an opportunity to assess prosthodontic volume. We can place implants at a depth that's compatible with fabricating a prosthesis, whether it's fixed, whether it's removable, whether it's an edentulous arch or a partially dentate arch. We know the space that we need to fabricate a restoration that's reliable and functional in every way. And it allows us to then predict where the implant should go and what modifications we need to make to the environment in order to minimize complications for the prosthesis and still maintain, from an implant point of view, adequate length and adequate diameter, so that the relationship between all of the interventions works better for the patient in the end. Now, you can then go ahead and transfer all of this information digitally if you like, but you still need information from the patient. This is a publication from my time at Louisville, but you can see the patient presents with a terminal dentition that's failing. On the right-hand side, the digital software allows you to plan for your denture position, but you still need some basic principles before you go to the computer. You need to have seen the patient and understand that we need to increase incisal length in the maxillary incisors, that we need to manage some occlusal plane disharmony, that we have some soft tissue that is also disharmonious and non-aesthetic. So on the right-hand side in the computer, you can come up with a very nice plan, but it has to fit if you're going to avoid the complication of teeth being in the wrong place. You still need to take information and see the patient before you start working on with software and planning where the teeth should go, because the teeth are absolutely critical to defining where the implant should be. If we had a fixed restoration, the implants most definitely could be more shallow The implant design may be bone level instead of tissue level, but the prosthesis itself requires less volume in order to perform in a manner that's satisfying to the clinician and the patient. So what we really need to do is define the prosthesis that we are going to provide for the patient first, and then work within the parameters of being conservative, but managing the oral environment, the biologic oral environment, so that it is conducive to an outcome that has some predictability and some evidence to support it in terms of longevity. So on the right-hand side, you see a printed or a milled cast that illustrates for you where the bone would be after the teeth are removed, and how we can develop a series of, in this case, stacked templates to communicate with our surgical partners so that we can remove and modify the biologic environment to best suit the restoration that we choose. Whether we fabricate the prosthesis using a digital workflow or whether we fabricate the prosthesis using a conventional pathway, what we have to understand is the basic principles of occlusion and interocclusal records and vertical dimension of occlusion. These will define where the teeth go. How the teeth are positioned and fabricated on a prosthesis is really only how they're done. It's not where they go. And that's an important thing for us to understand as well. Then we can go to the patient. We can use these stacked templates to, on the left-hand side, modify the biologic environment. On the right-hand side, still use a surgical template to communicate with the clinician placing the implant, where the implant should be in terms of supporting the prosthesis in the manner in which we would like it to be supported. Once that information has been transferred to implants in the patient's mouth, we can then intervene from a prosthodontic side with the prefabricated provisional prosthesis, whether it's immediate or whether it's early or whether it's delayed. We still have the information from the pathway that we used to plan, assess, and prefabricate restorations. And in the end, an immediate placement of our restorations, in this case, the mandibular fixed interim and a maxillary provisional complete denture, it allows us to change the patient's life in a manner that is positive. She's very happy with outcomes from an aesthetic point of view, from a functional point of view, and from a phonetic point of view. But it just doesn't miraculously get to that point. Avoiding a complication with each of those outcomes that we can measure, I can't, again, overstate the importance of understanding the environment in which you work, being able to use that information to develop a treatment plan that allows us to provide the kind of care that the patient's happy with. Whether we use inclined or tilted implants, or whether we use conventionally axial inclined implants, sometimes the patient brings different information to us. If the patient does not have strong biting forces, or is an elderly patient that really, from a nutritional point of view, it's not a good idea to compromise their functional capacity, we have the ability now to go ahead and position for patients implants that are inclined. This is well supported in the literature. You see here two citations, one by Dr. Lin and Eckert, that was able to identify for us that inclined implants work as well as axially inclined implants, as long as we have 4 or more splintered across an arch. That the clinician, if the clinician is able to intervene and the treatment plan is sound, it's important to recognize that 4 or more implants, it works. And this is something that Dr. Polito and his group were able to identify. No real difference between 4 or more implants in terms of outcome predictability. Again, but the intervention of the clinician is important, and the plan, how we are going to intervene, cannot be underestimated. And I think really one of the next things that we need to talk about, if we are going to work with a contemporary or a digital workflow, is that each stage of treatment needs to communicate with the next stage. Because if we start in the digital realm and then transfer some of our care into the conventional world, and then transfer it back into the digital world, and then maybe back into the conventional world, each time we transfer from digital to conventional or vice versa, we introduce an opportunity for a problem and a complication to occur. What we really know from the evidence is that if we stay in the conventional pathway, there's a lot of evidence to support that works. If we stay in the digital pathway, the evidence maybe is not so strong yet, and there's not as large a volume, but the evidence clearly indicates that the digital pathway also works. The key is that the clinical team understands the digital pathway as well as they understand the conventional. If you can do that, we can start with planning, and the surgical intervention and the prosthodontic intervention and the laboratory intervention can partner together so that we have an enhanced opportunity to provide care for the patient that's improved. This is a patient that was treated by Alejandro, the young guy from Chile, and I think this illustrates these points very well for you. It's a patient that you listen to the patient speak, you understand lip position, you utilize a try-in to visualize using the conventional pathway where his teeth need to be in order to provide a satisfying phonetic, aesthetic, and functional outcome. Once that information is gathered, whether we use a conventional pathway or a combination thereof, in this case articulated casts with a digitally prefabricated provisional restoration, the clinical team has to identify here where their skill set fits best with the patient. And we will talk about that soon, and really with each other, because if you do it right, we can take information that is confirmed using a standard traditional or conventional pathway, but the planning and the assessment and the diagnostic information or data gathering is all done in the digital realm and then transferred to the patient using communication tools that are fabricated and designed in the digital world. Here we have a surgical template that does that. In the end, you are able to provide the patient with an outcome that's satisfying in every way. We can use tilted implants. You don't have to. You can use axially inclined implants. We can use more or less implants. What we hear from a lot of speakers is a little bit of the dogmatic approach. In every instance I use this, or in every instance I do that. The evidence suggests design your restorations on an individual basis based upon the individual needs of each patient that you see, and you will reduce the likelihood of complication, because here we have a completely different kind of patient that has to be managed in a completely different way. She's much younger. You have to have a chronology of intervention that will transition her from this point when she's young with clearly dissatisfying teeth to a point when she's older where the implant therapy that we provide can alter her profile and her psychological well-being. But the foundation of this is knowing where the teeth go. There is no way of avoiding the try-in, whether the try-in is fabricated initially on a base plate using wax and denture teeth, and that information is then transferred into the computer, so via a dual scan methodology, and partnered with the CBCT information that gives us an idea of bone and where the remaining teeth are. We can then position implants and use a provisional restoration. In this case, it's called a prototype, that the patient can utilize for a period of time and help us understand any modifications that may be necessary before proceeding to an expensive and complex definitive restoration fabricated from zirconia. Zirconia is much more challenging to adjust than milled acrylic resin is, or milled composite. So your best way of avoiding a complication with the definitive prosthesis is really managing care of the patient with the provisional and becoming skilled at transferring the information you gather and the adjustments that you make to our technician partners or ourselves, so that the definitive restoration has already been managed to overcome problems that we see earlier in the treatment care. If we get that right, it's very possible, although more challenging, to fabricate a restoration using all of the modern technologies we have available to us. Here we have zirconia with what we would call micro veneers on the outside, providing the patient with a very satisfying aesthetic, phonetic, and functional outcome. These are important advances for us that the digital pathway or a contemporary pathway can provide, but they only provide, it's not the material and it's not the pathway, it's the ability of the clinician to utilize those enhanced methods to provide a restoration for the patient that's at least as good as what we can do in the conventional world. And we hope that it's better in terms of the outcomes for the patient, because if the occlusion is wrong, or if we get the aesthetics wrong, being able to modify and change what we see here on the screen irrevocably makes the restoration weaker, and it changes the likelihood that it will survive in the long term. It can alter how readily it's maintained by the patient during their time when they're not with the clinician, and by the clinician. But if you get it right, I have no doubts that the contemporary pathway provides the right clinician with an opportunity to exceed what we are able to do with the conventional world. And I think this is an important thing too, but the right clinician has to have the right ability. Not all clinicians are equally skilled. I wish they were, but they're not. Some clinicians are better than others. It's important to understand you need an appropriate level of education, an education that allows you to harmoniously evaluate the patient's existing condition, the restoration that we are going to provide, and how we are going to connect the patient to our restoration. And we need, really beyond education, experience. This should not be the first restoration that a entry-level implant clinician should be doing. And very often clinicians are encouraged to believe that a little bit of education allows them to change a lot of what they do in the clinic. And nothing could be further from the truth. You have to repeat. One of the things, again, that Professor Boozer said the other day when he was with us, is that he expects, if you don't do 50 single tooth restorations or implant placements in the aesthetic zone on an annual basis, you're not experienced enough to do it with predictability. And I think this is a very important statement, that you need to do the work in order to be able to be predictable. But if you do the work, you can transition a patient that's unhappy and has problems with aesthetics, phonetics, and masticatory function, and alter their world in a remarkable way that's very satisfying to the clinician and patient. But it's not zirconia, and it's not the digital pathway. It's a clinician that's appropriately skilled to utilize those tools to enhance where the patient goes. And this is something that we've been talking a lot about recently, is that implant procedures are dental procedures. When a patient walks in like this, for many years we've talked about implant dentistry. And you know, I think we're getting to a point where implant dentistry is part of dentistry the same way that extractions and endodontics and periodontics and prosthodontics are. There are straightforward procedures that are more straightforward with dental implants than fixed prosthodontics, for example. And yet the dental community still has problems embracing that, because a lot of dentists were never educated as part of their dental school training on how to think of implants the same way they think of fixed and removable prosthodontics. And I think this is an important thing for us to understand. Who will treat a patient like this in the future? In the past, if the patient said implants, it would go to an oral surgeon or a periodontist and a prosthodontist. Maybe in the near future, it might still do that, but in some instances go to a prosthodontist or a periodontist or an oral surgeon only. And it's far more likely that in the future it will go to a dentist. Who treats the patient then is all about what the dentist decides. Do they have the adequate skill set or education or experience to manage it, or should they refer? When we intervene will make a big difference on, or when we treat the patient is an important thing. We have to have this adequate skill set, or else it's not appropriate for the dentist. But when we intervene, immediate procedures, early procedures, delayed procedures, each of these has the capacity to alter the quality of the outcome. And whoever it is that decides to treat the patient needs to understand that, because it influences how we provide the care. And how we provide the care is ultimately, the patient's expectation is that decision will provide them with something that's reliable. And evidence is an important thing here. The clinician that provides the care needs to be appropriately educated with regards to the evidence. And this is an article that was published as part of the last ITI consensus conference. I was very fortunate to be in the same group as Gallucci and his collaborators. The most important thing that came out of this article, and there were many for me, is that treatment planning, inclusive of implant therapy, inclusive of placement and restoration. The treatment planning needs to start when the indication for tooth extraction has been confirmed, not after the tooth has been removed. A contemporary thought process should include, what do we do, and think about that before we actually take the tooth out. Because once you've taken the tooth out, the opportunities for the clinician are reduced instantly by that procedure. So this patient that comes in, before the tooth is extracted, we need to decide, are we going to place an implant or are we not? Are we going to immediately load the implant or are we not? Are we going to early load? Are we going to take out the tooth, allow it to heal, go with an early contour augmentation type protocol? If we take the tooth out, that decision is already made if we don't include everybody in the treatment team in the decision-making process. And I think this is a big change, because we live in a world where each clinician is becoming better educated to intervene in a broader sense. So if you look at a patient's photograph like this, in my eyes, you are not the clinician to treat the patient if you don't automatically understand the problems the patient brings. Accurate assessment and diagnosis is key before you decide to treat the patient. You have to see altered eruption patterns, gingival and mucosal, as well as tooth disharmony, incisal edge disharmony, alveolar ridge deficiencies, occlusal problems, aesthetic and spatial tension, as Professor Belser would say. If you don't see these problems, you can't treat them. So it looks fairly straightforward as two congenitally missing lateral incisors, but it's not straightforward if the patient's expectations include satisfying aesthetic outcomes, satisfying functional outcomes, which we know they all do. So being able to manage this patient is an important thing. A long time ago, prosthetic management of implants in the aesthetic zone, it's no less relevant today than it was then. This is an article again published in 2004. Frank Higginbottom was the lead author, but these collaborators were able to say to us, make your decisions first and understand what it is that you're going to want to achieve, because the left-hand side shows that our intervention is not perfect, but the right-hand side shows it is certainly satisfying to the patient. That's a happy smile. These restorations are maintainable, and everything from a biologic and a technical and a mechanical point of view is reliable based upon the information that we have available to us at this point. Aesthetic outcomes is something that's critical for the patient, and we need to understand what an aesthetic outcome is and what we expect from it if we are going to understand how to treat the patient in a manner that they're satisfied with. So what defines a successful rehabilitation? If you look here on the at the patient, the right-hand side central incisor is a restoration that was fabricated by Dr. Morton. If you look at its dimension and its width and line angles, dentists can always find fault with what other dentists do, but they miss the most critical part here, is that this restoration disappears into the patient's dentition. If I don't tell you what it is, this is really an aesthetic outcome that's founded on a lot of perfect protocol. Harmony with the face of the patient. When you look at a patient from 3 or 4 feet away, you don't notice that there's been any dental work done. The 2 lateral incisors here have been replaced. Harmony with the facial structures of the patient. This is the first level of aesthetic success that we should see. If we go in a little closer, aesthetic and healthy peri-implant tissues, I said to you before, it's not just the prosthetic intervention and it's not just the surgery. As a dentist, we are providing an outcome that links the biologic foundation of the patient with the prosthesis that we provide. So we have to ensure that the biology of the patient, the health and integrity is maintained while we treat the patient, and certainly what we do is designed to maintain it after we leave. Height, volume, color, contour of the tissues is a very important part of the aesthetic outcome, and that's an important thing for a clinician to understand if they're going to work in the aesthetic zone. And then, of course, the restoration itself needs to imitate the natural appearance of the missing teeth in terms of color, form, texture, size, optical properties. As prosthodontists, we focus very much on this as part of our everyday work. But sometimes the prosthodontist overlooks how that blends into the world of the patient. And I think that this is something that as I've aged, I've understood how much more complicated it is than we would like to think. And it was complicated enough that in the ITI Treatment Guide #1, published more than a decade ago, the first part of that textbook on how to manage single missing teeth in the aesthetic zone focused on what we call the aesthetic risk assessment. On the left-hand side of the table, none of these factors are new to the world of dentistry. What we did was simply put them in a table that allowed the clinician to evaluate without forgetting important factors right from the start before they intervene with the patient, and then decide how much risk is there. Because the goal is not a restoration that works for the patient. This is aesthetic risk assessment, and the goal is to identify patients who have a higher likelihood of a negative outcome so that we can address those circumstances before we intervene and start working with the patient. 10 years after the first one was published, the problems are still there. So it was repeated, essentially an update in ITI Treatment Guide #11. You see the authors here, Will, Vivian Chapuis, myself, and Daniel Boozer. There are some things that have been added in the ensuing decade: facial, bone wall, greater emphasis on the patient's expectation. These things have become more important, but the critical component hasn't changed. Before the clinician intervenes, they should make sure nothing is overlooked, especially from an aesthetic point of view. Obviously, some of these things are more important than others. They're red. If you have an edentulous span that's more than one tooth, if you have a facial wall, facial bone wall dimension that's less than 1 millimeter, or you have an unrealistic patient, all of these things have a greater influence on the outcome than any of the others. These are important things for us to focus on as we work forward with making decisions. And for me, I've always been an advocate for the team. I know that we live in a world where the prosthodontist or the periodontist or the surgeon, they want to think and they want to make decisions on their own, but it's always in the patient's benefit for us to gather information we don't have, and the team is a critical part of doing that. The team has choices to make and has decisions to make on behalf of each other. And as we work forward, patients are part of that team. Some present with endodontic failure, some with congenitally missing teeth, some with root resorption. How a patient turns up requiring care in the aesthetic zone can alter right from the start the opportunities that the treatment team has to make decisions. We can take a tooth out, allow the site to heal. We can then intervene with a contour augmentation or a graft, as you see in the middle, where the patient turns up with inadequate bone right from the start to support an implant that can be associated with a contour augmentation. And then other times we have circumstances that allow us to remove a tooth and place an implant. These decisions about when the implant is placed are not only decisions for the surgeon that's placing the implant, these are decisions also for the restorative dentist that has to restore, because the environment is altered by the decisions that are made at this point. Then, whether we fabricate a provisional restoration using screw retention, whether we fabricate a provisional restoration using contemporary or conventional pathway, for me, the important part here is fabricating a provisional restoration, initiating the treatment with something that reliably communicates where the final restoration is intended to be, so that we can encourage healing of the tissues around the provisional restoration. We can evaluate the aesthetic outcome, we can evaluate the functional outcome from the patient's point of view, and make better decisions as we move forward. Because from a prosthodontic point of view, we have a lot of decisions still to make. Conventional pathway using a combination of digital opportunities. On the left-hand side, you see a digitally fabricated crown, but you see a conventionally fabricated abutment. In the middle, patient was treated a long time ago when we used to use narrow neck implants, titanium components, and a metal ceramic crown. On the right-hand side, a precursor, if you like, to tie-base was the two-piece mandible abutment. This kind of intervention allows for flexibility for the team to then, utilizing all of these different alternatives, whichever one suits the individual patient or the individual edentulous space better for the patient, is the one the team should choose if reliability is important. Now, this is a patient that was treated by Waldemar and his team, but for me, what it clearly identifies is a problem that we have still in a contemporary world. This is what most dentists see, and they make decisions on how to manage the patient based upon what they see when the patient is in their chair. They don't see the CBCT scan, so they don't necessarily make good decisions based upon the implant. On the right-hand side, you see what many surgeons would see. I give them the benefit of the doubt here and say that they look at the tooth in the mouth and see something other than just a tooth that needs to be extracted. But on the right-hand side, we see the CBCT, and decisions about where to place the implant are usually made only by looking at the bone. The long axis inclination, the depth and the position of the implant is guided by the anatomic architecture that we see. And very often that doesn't communicate well with the position of the tooth that's being planted. So again, I emphasize the team should work together to make decisions. The surgical partner, from my point of view, once we've decided to take a tooth out and place an implant, and we've decided how we're going to restore it, and we've worked together as a team to define where the implant should go, the clinician placing the implant, if you're going to avoid complications like recession, aesthetic compromise in terms of occlusal reliability, your surgical partner has to give the implant the best opportunity to succeed. And that means understanding things like horizontal defect dimension, the importance of a stable implant, the importance of a stable facial bone wall that's of adequate volume, not only height, but width. This all together provides the implant with an opportunity to function from a biologic point of view, and it gives then the prosthetic partner the opportunity to fabricate provisional restorations, guide the tissue so that on the right-hand side we can provide a ceramic restoration that satisfies all of our demands that we establish at the start. Healthy tissue, healthy biology, aesthetic, functional, and phonetic outcome that's good for the patient. It disappears into the patient's life. Good decisions are made when you have all of the information, and good decisions are made when you have complete education. Sometimes that is something you don't have, but the education and the experience of a partner can often enhance the quality of the outcome for the patient. This is a patient that I treated, it was the first immediately placed implant, immediately restored implant that I did. And it was done maybe approaching 20 years ago. Tooth was removed, implant was placed, graft was positioned in the horizontal defect, and then a provisional restoration allowed the tissues to heal, and then we went ahead with an all ceramic crown. As you can see, under contoured. The contour was something that we would do today. And the outcome on the right-hand side is something that I was very proud of. This is the 5-year follow-up. But what we learned by following our patients, and this is an important thing, learn from the mistakes of others as well as yourself. What we see on the right-hand side now is the patient after 8 years of follow-up. And you can see now we have healthy tissue, but we have recession. We still have a healthy restoration. We still have a healthy implant. In many instances, according to the literature, this would be successful unless you looked at aesthetic parameters as your guide to success or failure. It's clearly a failure from my point of view, even though we can find success in the outcome because of the recession that we see. How to avoid the recession is something we are still learning about. Chris Evans and Stephen Chen talked to us about position of the implant, inclination of the implant, in particular, stay away from facial malpositioning. And then Vivian Chapuis, as part of Danny's group, what they are able to do is follow in the long term how one particular treatment protocol, contour augmentation, is able to help us to avoid these circumstances. But it's not comparative. And if we had just as many patients treated with different protocols, maybe we would observe different outcomes. Maybe we would observe the same. But this is why the literature and critical evaluation of it is important, because these two implants were placed using a contemporary digital pathway, and they're terrible. The outcome here is the implants need to be removed, and then the defect needs to be managed. And it needs to be managed with a focus on where do the teeth need to be. And I hate to say that some of the traditional literature, but this article by Coyce and Spear was published a long time ago, but it is no less relevant to the making of good decisions. Conventional, the education that we received in conventional dentistry is still relevant to the decisions that we make in a digital world, because the diagnostic wax up is, as you see on the left, if you look at the left-hand side, central, lateral, and canine, without modification of the soft tissue position to give us harmonious, a harmonious relationship from an aesthetic point of view with what we plan on the right-hand side, our outcome is compromised. And if you look at that wax up in the patient's mouth on the right-hand side, the wax up has a better aesthetic outcome than the natural teeth that we see. So we need to plan the wax up with an understanding that we are going to alter the environment into which the implants and the graft go by altering the teeth that allow us to find symmetry and proportion. These basic principles of aesthetics need to be addressed right from the beginning if our outcome is going to work well. And then we can really utilize a conventional and digital workflow to make life easy for us. And that means gather better information from the patient using CBCT. Digital impressions are something that are going to be part of our life more and more. People often say incorrectly that digital impressions are not as good as conventional, and this misunderstanding that conventional impressions are accurate. They're not accurate. Neither is accurate. Is the inaccuracy clinically relevant? Well, maybe that's a question that we should be looking at more. But certainly the ability to fabricate the restoration using printing and milling technology enhances our chances of providing a restoration that's biomechanically more sound. It also allows us to become more efficient, to treat more quickly with procedures that are less expensive, and that's important. So here is just a straightforward patient. It's not a patient. I chose this patient because I think too many speakers only show the absolute pinnacle of what they do. I'm old enough to be comfortable with what I've done and how I practice. So I want to show you a patient that I think will become everyday implant dentistry for everyday dentistry. I would anticipate in a short period of time that most dentists will be capable of treating a patient that presents in their practice like this. Fractured fixed partial denture, lost tooth. How to manage the patient is the same as it's always been. You make an impression, whether it's digital or whether it's conventional, it's still an impression that captures the circumstances of the patient. Then we go through a planning exercise to identify where we want the teeth to be. That's an important part of what we do. It's called a diagnostic wax up. Even if we're not using wax here, the process is still the same. It's a diagnostic procedure that identifies the end result before we start so that we can backtrack with planning. Then we can, on the right-hand side, combine this information with CBCT so that we can allow all of the information a better opportunity to enhance the decisions we make based upon a greater volume of knowledge. And this is an important thing for us. So what we see here is blue is CBCT. What you see in yellow is the optical scan, the intraoral scan. What you see in white is the plan, and you can see the implants as part of using a software package that allows us to visualize all of these things together. It then allows the clinician to prefabricate a surgical template. This is not a guide and it's not a stent. It's a surgical template. An important part of the digital realm is this has to fit accurately. A surgical guide of the past gave the surgeons an indication of where we wanted the implant to be. This kind of template communicates much more accurately where we want the implant to go for the restorations that we plan, because we are going to prefabricate the restorations to enhance the treatment chronology for the benefit of the patient. Whether we place it immediately or whether we place it early doesn't really matter. If you use a modern micro-roughened implant, what you have an opportunity to do is improve the relationship between the biologic foundation, the bone of the patient, and the implant that we place. So I would say here, avoiding complications means working with a contemporary partner in the corporate world that makes implants that are capable of cashing the check in terms of reliability, providing enough evidence for what we do so that we can confidently and confidently tell patients what to expect, and honestly, if you want to know the truth. So here is the way we would do this today. This is Randy. He's making a digital impression. Again, a patient that I would expect a lot of dentists to see at some point in the future. What we know is that the literature is not clear on this. We have articles like you see here from Tim Yoder and Urs Braga that were able to identify digital pathway is more efficient than conventional. What we have at the bottom is a study that was done by our group in Louisville that looked at the difference between polyvinyl siloxane and digital scanning for students. And we found in many ways outcomes that were different and opposite to what they found with Tim Yoder. I think the important part here is with training and expertise and experience, there's no doubt in my mind that digital impression making is more efficient than it is to make conventional impressions. And in the long term, it will be more reliable. Then we can make casts. You can print, you can mill, you can still fabricate. The thing about the casts is they have their own complications. They are much more rigid, they are much less susceptible to abrasion, etc. But if you leave them on your bench over a period of time, the ambient environment has a greater opportunity to influence their accuracy than others. But there are still positions for casts, as I'll relate to you in a minute. And then really the big change is the ability of software to communicate amongst itself. On the right-hand side, you see the CBCT, the positioning of the implant by the surgeon or the clinician that's going to place it. On the left-hand side, in real time, moving the implant on the right-hand side can alter what we are able to do with regards to the restoration on the left. So our software alternatives enhance the opportunity for communication between members of the team. So being able to leverage a contemporary digital workflow means using all of the opportunity it provides. If you only look at the CT, or if you only look at the prosthetic design software, you're missing an opportunity to improve the quality of care that you provide, and that's important. And here again on the right-hand side, you see the surgical template. It has observation windows. The partner that you have that will position the implant needs to know this has to fit. Very often surgical partners, their time is limited. One of the things I think a cast can still be used for is to adjust the surgical template before it goes to surgery, so that the clinician that will restore the implant can be confident it will be positionable in the same way in the patient as we designed it on the computer, because that's where our biggest problem can occur. Then we can prefabricate provisional restorations using contemporary pathway, digital pathway. Here we have restorations. You can mill or you can print these. You can then adjust the surface to modify the aesthetic outcome. And then we can take all of this information with us to the surgical appointment, position implants, according to the highest level of communication that we have available, ensure that they are adequate for loading protocol that you choose, and then position the provisional restorations. In this case, I know some of you will look at number 7 and say, well, it's not aesthetically pleasing, but you know, this is a 75-year-old patient, low smile line, no aesthetic demands at all, and still has a biologic foundation that can support an implant and a provisional. So sometimes just because we can do something doesn't mean we should, and we should not really introduce our own complications. So here in a 75-year-old patient, is it appropriate to have the patient wait for the healing of graft, have the patient pay for the procedure, when from an aesthetic point of view, that's the only enhancement you make, and that's not part of her demand. So I think the prosthodontist or the restoring dentist and the clinician placing the implant still should listen to the patient and provide an intervention that best suits the patient and their individual needs. But we communicate a lot more with orthodontists. On the other side of the coin, we have patients that are more demanding in terms of the aesthetic outcome, symmetry, proportion, inclination. These are still basic principles that are critical, and we need to be able to transfer that information through our digital technology if we're going to provide for the patient something that satisfies these demands. And here we use the right kind of implant, what we're learning to avoid aesthetic complications. Sometimes we need to use an implant that is smaller in terms of its diameter, which means it has to be stronger in terms of its material properties. And then we can avoid the biologic complication of being too close or proximity to adjacent teeth or adjacent implants. We know how deep they have to be so that we can develop an emergence profile that allows for the tissue to heal in an aesthetically pleasing way. And then, of course, we use implants that are compatible with the procedure that we choose. So we want to maximize the healing capacity. We want to be able to maximize the biologic interaction between the implant and the patient's bone. If we do that, we can intervene digitally or conventionally. But in our world, we will make a digital impression at the time of the placement. On the left-hand side, you have us initiating care with a conventional pathway, fabricating a provisional restoration. On the right-hand side, in the middle, you see that you can make a digital impression and pursue that pathway as well, depending upon how your team best works. And then we can use design software that allows for us to visualize the impact we have from an aesthetic point of view before we provide it even for the patient to trial. Some patients, this patient is aesthetic zone, not particularly high aesthetic demands, but in terms of the provisional restoration, she is much more satisfied with this a week after the provisionals were placed than she was beforehand. Her orthodontic work is done, her wearing of a provisional restoration that she was not confident in is over. So her life is much better, and this satisfies the demands that she has as well as the clinician. So really the decision to which pathway you follow depends on simplicity and efficiency. It needs to depend upon the patient. The ability of the clinician to utilize the pathway they choose is really something that is overlooked. Some clinicians, younger clinicians, are much more adept at understanding how a digital world works. So, start to conclude. Most problems are caused by the clinician. I hate to say it, but most problems are caused by the clinician. Here we have ideally positioned implants, but we have biologic complications, mechanical complications, and technical complications because the restorations were fabricated with poor contour. They were attached to the implants using a poorly executed method of cementation. And what you see is the end result of the intervention being less than ideal. But very often we are presented with implants that are poorly placed. No matter how good the restorative dentist is, finding an outcome that's satisfying from an aesthetic, phonetic, and functional point of view with these implants is impossible. So the position of the implant has to be compatible with the outcome. So in many ways, it is still the most critical part of what we do, because right from the start, it can eliminate a successful outcome. So when I said before, a bad implant is something I don't want to work with, I'd rather no implant, I can come up with a better outcome here for the patient without question, without the implants. Poor selection, inadequate education, inadequate experience, these are factors that we can never overcome. And the clinician is the most important outcome here. And this was a diagram published by Chen and Boozer in Treatment Guide 3. We spoke about these factors in Treatment Guide 2. The treatment approach is often the focus, and that's okay, as long as the clinician understands the ramifications of the approach that's chosen. The clinician is clearly the most critical part. The clinician chooses the patient, the clinician chooses the intervention, the clinician chooses the biomaterials. These should be individual decisions that are made based upon the circumstances of care. So to summarize the prosthodontic side, Bjarne Pedersen, as part of our group at the last consensus conference of the ITI, zirconia ceramic and metal ceramic, if it's a single crown, there's no real difference in 5-year survival rates if it's placed on an implant. The overall incidence of biologic and technical mechanical complications is still significant for both. Between 13 and 16% of single crowns present with some kind of problem. This is an important number, because it means 1 in 6 of these has a complication that the clinician will need to deal with. So this myth that clinicians perpetuate with patients, that implants are better choices than teeth, needs to be revisited, because a crown on a tooth, I don't anticipate this level or this percentage of complications, but it relies on the tooth being healthy. It relies on the environment being compatible with that. But the important thing here is, for single crowns, no real difference between zirconia and metal ceramic. This is zirconia metal ceramic can therefore be recommended for anterior and posterior single crowns that are implant supported. But an important part here is there is a difference when it comes to the aesthetic outcome. The zirconia ceramic restoration is more aesthetic than the metal ceramic. So depending upon the demands of the patient and the aesthetic expectations, this should be the decision for whether we choose zirconia or metal ceramic. Important here, monolithic and micro-veneered crowns, while promising, there is inadequate existing evidence to support these being a first choice. So really, and they are a first choice for many clinicians, but the decision is then a professional one made by the clinician. And it's important to recognize that professionals can make those decisions. It's okay to deviate sometimes from the evidence if in the hands of the professional, the outcome can be enhanced. And that's important for us to look at. Irina Saylor and her group, they wrote a systematic review that addressed zirconia ceramic and metal ceramic for fixed partial dentures. And what they found was zirconia ceramic exhibits significantly lower 5-year survival rates when compared to metal ceramic. Now, this is an important statement, because I listen to people all the time, in a fixed partial denture here at the back of the mouth that you see in the mandible, it's fabricated with zirconia ceramic because the assumption is it's better. Whether it's hype from a company, whether it's hype from the laboratory technician, it's still hype while ever the evidence suggests metal ceramic might be a better alternative. And it's a big difference. They fail 5% difference, which is a big difference. Significantly more problems. Chipping is the major concern, obviously. Most people are familiar with that now. So, and the bottom line, our group, of which both Bjarne and Irina were part of, as well as my partners here, Waldemar and Wei Xiao, zirconia ceramic cannot be recommended as a first treatment option for implant-supported fixed partial dentures. That's the key, and that our group found consensus making that statement. Once our group did, the larger group, the plenary group, also agreed. They have to agree if the statement is going to be made on behalf of the group, and the whole group agreed. When utilized, patients should be informed of risk. So this means even if it's not a first treatment option as a recommendation, doesn't stop people from utilizing this technology. But if you do, it's only fair to tell the patients, I think this is a good choice, but the evidence so far is not as compelling. Metal ceramic should remain the first option. If you want to know more about the materials, there's a ton of information out there. This article by John Burgess will give you a state of the art, if you like. And below, Kenny Malaman is about to publish a similar kind of long-term documentation on EMAX. These are leaders in ceramic research. I'm not a ceramic research guru, so I rely on a lot of this information that I get from them. What I can tell you from a clinical point of view, you can get outcomes that are satisfying in a manner that you can't get with the alternative. So while I believe there is a lack of some evidence in this digital world, I also believe the outcomes are improved. So it really then becomes a balance of each professional to make better decisions. So prevent problems by planning appropriately. Gather all the information you need. Make individual decisions for each patient that can be as simple as, do I do a bar, or do I locators, or do I do a fixed metal ceramic or an all ceramic? How many implants you choose. Avoiding complications means gathering the right information and having the team select a pathway and a chronology that benefits the patient. And then design for durability. Don't overlook basic principles that we've learned from dentistry over a long period of time. If you ignore some of these basic dental principles, you do so at not only your own risk, but risk for the patient. So I don't know how long it's taken. I hope we haven't gone over, but I appreciate the Saudi Prosthodontic Association on behalf of all of us here in Indianapolis. Even though we're sitting at home, at some point in the future, I imagine the Indianapolis 500 will come back, and I imagine we will see football again. And I think everybody is looking forward to this. If you would like to get a PDF, you can use your phone to get the QR code now. I'll leave it up for a couple of minutes, but if you get that, you should be able to gain access to the PDF, and I'll make it available to everyone for a couple of weeks so that you can download it if you so choose. So with that being said, thank you very much for spending some time with me for this afternoon. On behalf again of Indiana University, who support everything that I do from a perspective of the role I play. I can't thank them enough, and I can't thank you enough for spending the time with me. Thank you.
Dr. Morton, thank you very much. As always, it's a pleasure getting to hear you speak. I've been hearing you speak for 3 years, and I always learn something new every time I hear one of your lectures. So thank you very much. And I believe on behalf of all the attendees, we would like to thank you for a very informative and valuable lecture. And okay. I think Dr. Anas, I don't know if he wants to add anything, but he'll take you through the question and answer phase. Thank you.
Okay, can I stop sharing now?
Yes. Yes, Doc. Yes, please. 1 second, please.
There you go. All right, I see you all.
Okay, Dr. Dean, thank you so much for your amazing, well-informative lecture. We indeed learned a lot from you in how to avoid and manage prosthodontic complications. Again, just as a reminder for our dear participants, as the number of attendees of scientific webinar activity presented by the Saudi Prosthodontic Society has increased dramatically in the past days, it has been decided to add an additional daily prize for those who win the daily competition. In addition to a free membership, the winner will receive a voucher of 1,500 Saudi riyals provided by Amasya Tamayiz Company. The award will be provided until April the 19th of 2020. So Dr. Dean, you can see in front of you the Q&A section.
Yep.
Yeah, and beside each question, you have two options, the answer live and type an answer. Before answering any question, could you please press on the answer live and then answer the question? After you're done, just type answer live on the second question that you're about to answer. Okay.
Okay. So
Thanks.
I just click, I'll just answer it live. So
Exactly. So that the attendees will see the questions. They have a different platform. They don't see all the questions. They only see the questions that you press answer live.
okay. Well, number one, I appreciate the kind comments from people on the question segment. So, but that's not a question. So I'll go to the next one. Answer live. So click answer live. How long can I leave the patient with the provisional before delivering the final prosthesis? Well, I would tell you, I think you have to leave the patient in the provisional restoration until you have learned all of the information that you seek. So the biggest influence here is the quality of the provisional restoration. If you take time to fabricate a provisional that's reliable from a biomechanical point of view, and this is one of the things that the digital world allows us to do. We can mill and print provisional restorations that are more reliable than those, for instance, that are custom fabricated chairside. For each patient that we treat in the aesthetic zone, we provide a provisional restoration with the appropriate emergence profile, and we do what we call a tissue check between 4 and 6 weeks. We then evaluate how the patient has responded to the provisional restoration. And this means you have to be able to read the tissue response. If you have a black triangle, for example, it means underneath the tissue, you're under contour. It might be the adjacent tooth, it might be the provisional restoration, but either way, you have to provide more support for the tissue to maximize the ability of the papilla to reach its ideal height. If the papilla is blunted in the absence of inflammation, it can mean you're over contour. So how long do I leave the patient? I leave the patient for a minimum of 4 to 6 weeks to assess the tissue in a single tooth or a partially dentate patient. I would say for an edentulous patient, if you make a really good provisional restoration that's screw retained, that provides for the patient what you plan to do in the future, it then becomes, how long can you leave it? You can leave it as long as it is able to provide the patient with service. There's no reason not to. Depending upon how difficult the patient's care is, how hard it is for them to learn to work with the prosthesis that we provide, it can be anywhere again between 4 weeks and 6 months. It's not unusual for patients to wear a provisional for 6 months, whether it's partially dentate or whether it's edentulous. But I think you can, again, leave it as long as you need to. Okay, what do you think, answer live, what do you think of socket shield? You know, I don't place many implants. I've got a really good team that places them. But I have a lot of really good friends that I believe the information that they provide me with because of their experience and their knowledge and their skill. What I would tell you is, I think socket shield works. But when it doesn't work, it's going to be catastrophic. And I think there is, certainly I know for sure, the evidence to support socket shield is nowhere near as compelling in terms of longevity or quality. And so when clinicians say it works as well as alternatives that do have a greater degree of evidence supporting them, it's very difficult for me to see that as something that's credible. Yes, it works, but I would not use it because I think it adds a focus of complication. What we do know works is take the tooth out, allow it to heal, place an implant with the contour augmentation, using autogenous bone against an active micro-roughened implant, cover that with a material low resorption rate or low substitution rate with a membrane, gives us everything that a socket shield professes to provide. But it does so with 10 years of clinical evidence to support it. So while I'm not an advocate for saying everyone should treat everything in the same way, I am an advocate for minimizing choices that provide for an opportunity for complication. So in very simple terms, in the hands of the best people, there's no doubt it works. in the hands of a majority, I would say maybe there are alternatives that I would choose. The next one is, thank you very much. I would like to ask, what is the software that you use for planning? Okay, well, I was asked not to provide any manufacturer names as part of the scientific part of the program, but I would tell you, I think whatever software you choose needs to be compatible with every other part of care that you provide. So, you know, I showed a slide that was very straightforward. Whatever you use to capture the digital volume, it needs to be compatible with the software that you're going to use to then evaluate where you want to place the implant. That needs to be compatible with the design software from a prosthodontics point of view, and they need to be able to talk to each other. Then that process needs to communicate with the laboratory side if you're going to be able to mill or print. I don't know, Anas, can I say the name of the printer, the software we use?
Well, doctor, to be honest, if you were told not to do so, you know
Well,
better than I do.
Yeah, I thought it was in the contract that you had me sign, but you know, I can only get into trouble. We use Co-Diagnostics, and we use the partnering prosthodontic software. So it's all provided by the one manufacturer. Okay, then I don't think I deviated too far from that. Does all on-4 concept can be done in a patient having ideal bone volume? Well, it depends what you define as ideal bone volume. You can have too much bone. If you put 4 implants, you see, this is one of the problems I think with all on 4, is a patient comes in, not all patients with a terminal dentition have lost similar amounts of bone. Some have had more resorption than others. The problem that we encounter is the prosthesis that you provide with all on 4, every prosthesis needs the same volume, even if the bone volume is different. So if the implants are placed too shallow, we're pushing the volume of the prosthesis into, for instance, the vertical dimension of occlusion of the patient, which they may not be able to tolerate. If the implants are osseointegrated, the only way to manage that is to reduce the ideal form of the prosthesis. So ideal bone volume, yes, you can do all on 4, but for me, the ideal bone volume is one that can support the implants, support an adequate number of adequate diameter implants to facilitate a prosthesis fabrication that's reliable in the long term, which means it's biomechanically correctly formed, and it needs to be reliable from an aesthetic, phonetic, and functional point of view. Sometimes ideal bone means we have to take away because excess is not ideal either. You know, is it established for the sake of economical concern? You know, I don't really want to make a statement because I think we should make an ethical decision for the patient. It's not right or wrong to treat a patient differently, depending upon the demands of the patient from a financial point of view. Of course, the financial components make a difference. Some patients get dentures and no implants because of an inability to pay for implants. But I would love to provide every patient that's indicated for an implant with an implant, but it doesn't work out that way. But the driving force of your choice as a clinician should not be economics. That's a decision for the patient to make. As a clinician, your obligation is to evaluate and gather all the information you can, develop treatment options for the patient, and be prepared to discuss them so that the patient can then make a choice about what treatment to pursue based upon the information you provide from a prosthodontic and surgical point of view, as well as a financial point of view that only they know. So minimal bone volume patient, I think the literature is pretty strong that even one implant can help stabilize a denture. So in a patient that has very little bone, you can use a small number of implants, preferably 2 or more, to support, stabilize, and retain even a denture. And the patient will be thankful if you do that. Do you think early or late?
Dr. Dean?
Yeah.
Sorry for cutting you off. Due to time restrictions, can we take 2 more questions?
Oh, okay.
Thanks.
I don't know. I'm just going to make sure. I don't. Okay. I'm going to answer 2 of these. I don't. Yes, there are. It's not so much. Well, the question was, can the dentist work without a technician? I don't know, but I don't think being a technician is the same as being a dentist. And if you spend your time as a dentist being a technician, you're not a very good one usually. So you don't spend as much time learning about dental technology as you do about learning to be a dentist. So you might be a great dentist, but a terrible technologist. So you need to partner with somebody that's capable of doing well from a technology point of view. It's the same as the surgery. You know, we can all do surgery, but if we partner with someone that does it better, the outcome is better for the patient. I would say the technician is another member of the team, equally as important as the prosthodontist, dentist, or the surgeon placing the implants. So you can make a choice at that point. The space, you know, I don't like a space. None of my patients like space, but I like it to be cleansable. So it needs to be convex at all times. If it's going to touch the tissue, we use modified ridge lap Pontics. We put the implants in the right place so that we can develop emergence profile. If things are fixed, mutually protected occlusion, of course, is something that we would balance. And really, I wish I had time to talk about all the design ramifications, but those are the 2 things that I would recommend. For my email, I didn't provide the email because I have 7,000 unanswered emails, and I don't want to encourage you all to think that I won't. Yes, but if you all have a way of contacting Ahmad, which I'm sure most of you do, or Anas, if you contact Ahmad, he has my email address, so he can pass it on. And if you'd like, I'll say it once so that everybody has it. But I'll give it to you on the understanding that you have limited expectations of how quickly I will respond. It's DEA, all small, lowercase, DEAMORTO at IU.edu. DEAMORTO at IU.edu. Okay?
Thank you so much, Doctor, for your valuable time in answering our attendees' question. And as usual, dear attendees, you can go to our Twitter account and answer Dr. Dean's mortal question to get a chance to win our prize. And by the end of this webinar, on behalf of the Saudi Prosthodontics Society and the American Prosthodontics Society, we would like to thank you all for your attendance and your time. We really hope you enjoyed Dr. Dean's lecture and gained as much information as you could from his session. Dr. Dean, Dr. Ahmed, Dr. Faisal, and myself are so glad we had the opportunity to host your session. Please stay home, stay safe, and stay tuned for our webinar session with Dr. Radi Masri tomorrow at the same time. See you.
You will enjoy that. He's a close friend of mine, and we work together on the American board. So I can only encourage you all to attend.
Thanks a lot,
Thank
Dr.
you.
Dean.
Okay.
See you later. Okay.
Cheers,
Bye,
everybody.
Doctor.
Bye-bye.
Cheers. Bye.